For some reason, PowerPoint's taking its time this morning. All right, so this is going to be a little bit more of an interactive class. So I guess I want you guys to kind of think about things as we're working through this, as far as what you would need to do for a case, how you would personally prepare for things, and then what you're actually going to see when you get to clinicals varies pretty greatly. I can tell you some clinical sites, you're going to show up, and day one, you're going to take a written Pharm test. So be prepared for that. The good news is it's a lot of the same stuff we're talking about here. The downside is if you haven't studied or you haven't paid attention to it in several months, it's going to be a little bit harder for you. So think about things that are kind of basic, that are easy to ask. So dosages are a big part of that. So I would make sure I paid attention to those. I'm going to bring up the reference guide for us to kind of work through as a group as we start off. I'll try and make this a little bit bigger for you guys. So you will see, as far as the practice you go to, there's some regional variation in terms of what they use for sedation. Most commonly, it's going to be midazolam, usually between 1 and 5 milligrams. Some places they use 2 milligrams for everybody. Some places they use 5 milligrams for everybody. There is a growing trend to not use benzos and instead use dexmedetomidine. Now, when we do that, generally we're going to have to reconstitute it or draw it out of a bag. So you'll either have it in a 400 mics and 100 ml bag, or you'll have to reconstitute it with a 200 micrograms and 2 ml vial. So be familiar with what you have. Some places you will have formulations available to you. So it's kind of your choice as far as what you wind up with and how you administer it. But usually from that perspective, if it's being given for a anxiolysis perspective, it's going to be somewhere between 5 and 10 micrograms. The higher loading dosages tend to make your patient kind of obtunded from that perspective. Also, while you're doing this, make sure you're aware of your reversal agents. For your benzos, it's going to be flumazenil. For dexmedetomidine, it's really going to be the tincture of thyme. And then also be familiar with the ill effects that come with flumazenil. So if you give too much flumazenil, they tend to seize, which is kind of bad form on your first day in the operating room. Opioids, you're going to see the most common one we use is fentanyl. Generally, it's going to be 1 to 2 micrograms per kilogram. But there are places where they use lots of hydromorphone, so you may not use any fentanyl at all. You may also go someplace, especially for pediatric facilities, where they just use morphine. So again, be familiar with whatever you have available. Fentanyl is generally supplied in that 50 mics per ml. Morphine is highly variable, and hydromorphone usually comes in 2 milligrams per ml, and it gets reconstituted to 1 milligram per ml. So be very familiar with the concentrations you have available to you, because a lot of times when those things change, that's where we get into medication errors, because we didn't notice that it had changed. Induction agents, propofol is going to be by far the most common. You use 2 milligrams per kilogram, etomidate 0.3 milligrams per kilogram, and ketamine 0.5 to 1.5 milligrams per kilogram. You may also use Versed for induction in a 0.1 milligram per kilogram dose. This table with the inhalation agents, I would make sure I had that memorized, because especially if you're going to one of those places where you do have to take a written test, that's going to be on there. The other part of that is that almost everybody is going to ask you for the MAC values of these gases. So when you're trying to dial up a gas for somebody and you can't even tell them what the dose is, it doesn't sit real well. So when you start off in the operating room, a lot of these basic questions are kind of how you establish your credibility. So when they're asking you normal dosage questions or like dosage questions for induction medications, and you can't answer them, it doesn't sit well with lots of people. So make sure you pay attention to that and have it ready. Muscle relaxants, big questions there you're going to run into. the dosage, and then the onset and duration. So just remember that succinylcholine is really the only short-acting agent we have. Your dose is usually 1 milligram per kilogram. You may see that if it's being given IM or something like that, you may increase to 2 milligrams or even 4 milligrams per kilogram. There is some variation there. Intermediate acting agents, vecuronium, rocuronium. Dose for your VEC is 0.1 milligrams per kilogram. You're going to have to reconstitute this. So it's going to come in a powder vial, and you're going to reconstitute it with sterile water to 1 milligram per ml. Remember, it's a little bit slower onset. Even though the book answer is 2 to 3 minutes for VEC and ROC both, you'll see that ROC tends to be slightly faster than that, probably about half the time of VEC. ROC also has a shorter duration of action, but it tends to be somewhat unpredictable, especially with repeated doses. So if you're having to give multiple doses, you may see that it doesn't respond quite the way you want. So a lot of providers will transition to vecuronium because it is more predictable. You may go someplace where they still use pancuronium. It's really our only long-acting agent we have. Big thing to remember with pancuronium is that it is kind of a big boost to your sympathetic system. So if you have somebody that's hypotensive, it may be beneficial for you to use that. Duration of action, 1 to 2 hours if you give that full dose. To reverse this, you're going to use one of two agents, either neostigmine and glycopyrrolate or Sagamidex. Usually when I'm dosing my neostigmine, I go ahead and just go with the high end of dosing, especially as we've realized that we're seeing a large percentage of our population that is under-reversed at the end of the case. So what you'll do is take 0.07 milligrams times the patient's weight, and then you're going to figure out, so it winds up being 4.9 milligrams, round that to 5. So I've got 5 milligrams of neostigmine, and then I need to match that with an anticholinergic agent to prevent bradycardia. The most common agent we use is glycopyrrolate. So from that perspective, it will be 5 milligrams of neostigmine with 1 milligram or 5 mLs of glycopyrrolate. A lot of times in pediatric patients, because they're so heart rate dependent, we go ahead and keep that 1-to-1 ratio. So 1 milliliter of neostigmine to 1 milliliter of glycopyrrolate. With adult patients, to try and prevent tachycardia, especially if you've got somebody that's got a cardiac history, a lot of times what we will do is just decrease that dose of glycopyrrolate by 1 milliliter. So for this patient we're talking about here, I would administer 5 milligrams of neostigmine and 0.8 milligrams or 4 mLs of glycopyrrolate. And that tends to prevent the substantial bradycardia that you encounter. Things to keep in mind if you have to transition to any of the other anticholinergic agents, your duration of action and your onset time. So Gamidex, the dosing is 2 to 16 milligrams per kilogram, and you can really go into depth there, but it's based off of how many twitches the patient has. The book answer for onset is 1 to 4 minutes. It's very quick. With that in mind, sometimes if we're using neostigmine and glycopyrrolate, we'll administer it on the back end of the case or as the patient's starting to wake up, and that's fine. With Sagamidex, though, you almost have like a violent wake up. A lot of times they'll sit up or they'll start quickly moving. So if you're administering your reversal while the surgeon's still closing, it could be problematic for you because nobody wants the patient sitting up in the middle of closing. Or if you have somebody that's like prone or you have somebody that's in stirrups, something like that. So just be very cautious with that. There are lots of places that you have to meet certain criteria to administer Sagamidex to patients. So make sure you're familiar with whatever those criteria are. Usually it's pulmonary disease, obesity, long cases, or the need for urgent reversal of neuromuscular blockade. Any questions on any of those medications we've talked about so far? All right. So we're going to talk a little bit in kind of a scenario perspective. Say I have a patient that's coming in and they're going to have a lab chole done. What medications do I want to put together for this patient? So what's the first thing we want to have? And you can say it, you can put it in the chat, any of those sorts of things are fine. Or I can sit here and quietly talk to myself. Thank you, Brooke. Okay, so we're going to administer midazolam, usually in the pre-op area. Some places you will see that you write an order, and the pre-op nurse may administer your PO pre-meds or your IV pre-meds. So that may include your Versed. It may also include like Decadron or something like that, or any of the PO stuff, Tylenol, gabapentin, what have you. So what dose would we give a healthy 35-year-old female of midazolam? Yeah, 2 milligrams is kind of the standard dose. If you have somebody that's a heavy druggie or very anxious, you may consider increasing it. If you have somebody that's older, morbidly obese, poorly oxygenating at baseline, you may not want to give them anything. Let the patient kind of drive whether or not you give them an anxiolytic. If the patient's perfectly calm, you don't necessarily have to give them anything at all. On the other hand, like I said, if you have somebody that's strung out or they're very anxious, you may need to give them more than that. You may also see on the back end you have to give sometimes some Ativan in recovery, just because they're so anxious or upset about what's going on that they can't get past themselves to stop being in pain or stop being anxious. All right, so we've got our anxiolysis taken care of. Now, as far as induction agents, what medications are appropriate for a gallbladder? So what if we don't have fentanyl? How much morphine would we give this patient? How many milligrams? So Andy copied the answer sheet that said 1 to 10 milligrams. So what's an appropriate dose? So I'm going to go with Rick's answer. 4 milligrams is usually the easiest. Something else for you to think about if you're having to give morphine is how you reconstitute it. So like I told you, you have varied concentrations. So you may get 10 milligrams per ml. You may get 4 milligrams per ml. So that may affect your dosing. I usually do even numbers just because it's like my little OCD thing. But something for you to think about is if I have 10 milligrams and I'm going to reconstitute it, how do I want to reconstitute it? So if I've got a pediatric patient, I'm probably going to reconstitute it to 1 milligram per ml. If I've got an adult patient, I may do, 5 milligrams per ml, 2.5 milligrams per ml, something like that. A good starting dose is probably 2 to 4 milligrams for this patient. But like I said, think about how it's applied. All right, what about for fentanyl dosing? What's a good starting point for this patient? This should be an easy one. You guys have been talking about fentanyl dosing since school started. Yeah, 50 to 100 mics is a good starting point. I tend to front load my narcotics, so I'll usually give 100 mics up front and then not give anything else. What if we're going to give Dilaudid? What would be a good dose of Dilaudid for this case? Yeah, I would start off with probably just a milligram. You can always give more, especially with your opioids. It's a little bit harder to take it back. So what I usually do is reconstitute mine. Most of the time it's 2 milligrams in 1 ml. I'll reconstitute it to 2 mLs, and then I'll give a half milligram at a time. So 0.5 to 1 milligram is probably a reasonable place to start. One thing you have to keep in mind, we get very used to like quick onsets with a lot of our medications. Remember, your morphine and your Dilaudid are going to have a lot longer onset time. So you may be trying to give more and it hasn't actually kicked into effect yet. So just think about that with those medications. All right, so we've got our anxiolysis taken care of. We've got our analgesia taken care of. What do we want to give for induction? So propofol is probably the most common. What's a good weight-based dose? Actually, Grayson, you laugh. I had a case in EP yesterday. Guy's EF was somewhere between 5 and 10% for a TE cardioversion. So I got him to gargle some viscous lidocaine and then gave him like 4 milligrams of etomidate, and he zonked out. But we got to recovery, and you will see this when you get there, and you guys probably have already experienced this, that you realize you don't know anything about anesthesia until you start doing anesthesia. So the nurses are very, focused on how you did what you did, and they've got a lot of expertise, even though they may not have it quite based the way they want it to. So she's like, well, how much propofol did you give him? I said, none, because the propofol probably would have killed him. And she said, well, we have a whole discussion about the pharmacokinetics of things like that. And they don't even realize sometimes that the medication they think we give everybody isn't what we give everybody. And there is more to anesthesia than just doing the same thing every time. So just something for you to think about. Grayson asked about doing ketamine gargle for some cases. You can. I know a lot of times for like peritonsillar abscesses and tonsils, they'll do ketamine gargles. I've never actually done it. I usually just do the viscous lidocaine, get them to swish it around in their mouth, get them to gargle it, and then swallow it, and it numbs things up pretty well. If you have a cooperative patient, they really don't even need sedation for an EGD or a T after that. All right, so propofol 2 mg per kg, and then we need to come up with a neuromuscular blocking agent. So what would be an appropriate agent for this patient? All right, so ROC 0.6 milligrams per kilogram. One thing for you to think about with gallbladders is that they're a little bit elevated risk for nausea and vomiting. So depending on what's going on, you may want to go ahead and increase that dosage. So you'll see some controversy, and you'll also see that this is kind of highly regional variation. Lots of places will just use ROC period. Other places will use SUCS for induction and then keep the patient relaxed with ROC. So usually if they're putting in trocars, they're going to want the patient relaxed. They don't have to be, but sometimes when they're working laparoscopically, if the patient starts breathing, it can be kind of confusing and troublesome for them. So I usually use ROC, but you can use SUCS and then go to ROC. One thing for you to think about is that there's just a lot of ill effects that do come with the administration of SUCS. So if we're going to use SUCS, what's our dosage? So 1 to 5 milligrams. And if we're going to use SUCS, what else do we need to give along with it? What's one of the big issues we run into administering SUCS? Yeah, something to defasciculate the patient. So 2 approaches to it. Like Kayla said, you could do like 5 to 10 milligrams of ROC, or you can give like a 1/10 dose of succinylcholine. Just be cautious if you do that 1/10 dose that you've given them some sedation, because they will start to get a little bit weak and feel like they can't breathe. If you don't give them any sedation, it's kind of scary for them. So a lot of times what I'll do is push my lidocaine. They've already had Versed at that point usually. Push my lidocaine, push my fentanyl, and then I'll give that 1/10 dose of SUCS immediately followed by propofol. And then after the propofol is in, I'll give the full dose of SUCS. And that's usually enough to give them time to get that into circulation. So definitely something to think about there. Things for you to think about from an anesthesia perspective. A lot of times we get into situations, especially with sicker people, where they just are not tolerating the anesthetic, especially the gases, very well. So you may wind up having to sedate the patient so they don't have any sort of recall, and then keep them relaxed during the case. So in that case, just make sure you're using something longer lasting. Obviously not a good time to use SUCS. We used to do SUCS strips a long time ago, but we've kind of backed away from that. All right, so we've got the patient induced. tube is in, what other medications do we want to give post-induction or during the maintenance phase of the case? Samantha asked about the defaciculating dose being a non-depolarizer. Yes, you can either use rocuronium or VEC. Just things for you to think about is, your onset time. So like if I do a defaciculating dose of VEC, I know it's going to take quite a bit longer. Isaac asked about doing a suck strip. So when we do ECTs, I don't know that they do it anymore, and I haven't done an ECT in several years. We used to go ahead and just give them Revitol. But you would just put like a couple 100 milligrams of sucks in a 100 ml bag and just keep them slowly dripping in there. But we've got better choices now. All right. So Grayson said you definitely want to start gas after induction. Yeah, having your patient awake is probably not so good. So if we're going to use, say, sevoflurane to start off with, what's our MAC of sevoflurane? Yeah, 1.8 to 2. A caution for you is that a lot of times what you dial in on the vaporizer will not be what's actually being delivered to the patient. These highly calibrated devices we have may be inaccurate. So pay attention to what's actually being delivered to the patient. The other thing for you to think about is you're responsible for delivering that gas to the patient. So your flow rate, as far as your oxygen, air, nitrous, whatever you have going, affects how quickly that gas gets in there. So a lot of times post-induction, I'll just let it go in slowly because I've just given them a whole bunch of sedation. Sometimes their blood pressure is a little bit on the lower side. And if I immediately blast them with a MAC of gas, I may create some problems for myself. So I may start off with turning it to that, 1.8% SIVO to deliver. But instead of turning my flow rate up high to get it to the patient quickly, I may just leave it at like 2 or 3 liters to slowly trickle in. Obviously, keep an eye on your patient and their hemodynamic response, but that's just something for you to think about. So what if we were going to use isoflurane instead of using SIVO? What's our MAC? Yeah, the references are kind of variable. 1.1 is usually a good point. Some places will say like 1.17, some play 1.14, but something between 1.1 and 1.2. Things for you to think about as far as one gas versus another, the type of case and how you're employing it. So if you've got somebody that's got a little bit more reactive airway, sevoflurane may be good, DES may be bad. If you've got somebody that you're doing a mask induction on, like a kid, sevoflurane may be good. DES or ISO, just because they're a little bit more pungent, may be bad for the patient. On the other hand, DES tends to stick around a little bit longer, but you also tend to get a more profound sedation and relaxation at a lower dose without a lot of the hemodynamic effects you see with higher doses of SIVO. So there's trade-offs for each one. What if we were going to use desflurane? And you may see this a lot of times, like surgery centers that do a lot of gallbladders will use DES for lots of things. Just because of the environmental impact, I suspect we'll see DES go away in y'all's lifetime, if not, mine. But so MAC 6.6, be very cautious as you're turning DES on that you don't just blast them. Like I was talking about, kind of go up in a stepwise fashion. So turn it up to 2, turn it up to 4, turn it up to 6. Rapid onset will cause tachycardia, and you may also see that it causes some respiratory abnormalities and coughing. So advantages of DES. No, ISO stays longer than SIVO. If I said DES, I'm sorry. ISO tends to stick around a lot longer than SIVO does. DES sticks around a lot less than SIVO does. Advantages of DES, because it's not absorbed very well quickly, it tends to go away pretty fast. The downside is it seems to be somewhat time dependent. So if you're doing like a long case, I've seen different references, but somewhere between 2 and 3 hours, you lose the benefit of using DES for a lot of those patients. But if you have somebody that's big or a case that's pretty short and you don't want the gas, maybe you want them wide awake on the back end, DES may be a good choice for you. Because you don't get a lot of the sedation at the lower doses, they tend to cough a lot because it's kind of irritating as it's going away. So that's just something for you to think about. If you are using DES, you generally have to make sure they're pretty comfortable. Is that the actual comparison, Grayson? A ton of coal? I mean, I know it's the most environmentally damaging of the gases, but that seems really high. It's bad, nonetheless. That's still crazy. Like 1 bottle of DES is the equivalent of 1,000 pounds of coal. Okay, so we've got our gas going. A couple people had mentioned some sort of antiemetic agents. So what do we want to give this patient for antiemetics? Yeah, our go-to for pretty much everybody is Zofran. Most of these patients, we're also going to give them Decadron as well. Gallbladders are not terribly painful. In fact, most of the pain comes from the gas itself. It's not the surgical site. But you do, like I mentioned earlier, have a little bit of an elevated incidence of nausea and vomiting. So that's why I usually try and make sure I get them with a couple good antiemetics to start off with. What other medications can you consider giving this patient towards the back end of things? What might be beneficial, especially for, say, analgesia as we're headed towards wake up? What non-opioid analgesics can we use? You could use magnesium. Usually magnesium and Tylenol we're going to do up front. There's something else we use a lot of times for these patients. Same thing with gabapentin. You probably want to give that up front. Yeah, Toradol is a good choice for these patients. If you don't have severe renal issues or bleeding risk, I would consider Toradol. It's pretty beneficial. It's low risk for a lot of these patients. All right, so we give our Toradol, and now we need to reverse our neuromuscular blockade. So if she weighs 70 kilograms, how much reversal are we going to give her? Okay, so this is that 4.9 milligrams of Neo I was talking about. How much glycopyrrolate are we going to give her? Good. What if she weighs 50 kilograms? So 3.5 milligrams of neostigmine, and how much glyco? So remember, we're going to match up ml per ml. So if I'm giving 3.5 mLs of neostigmine, it's 3.5 milligrams. So then I want to give 0.7 milligrams if I'm doing 1-to-1. If I'm considering decreasing it, I'll probably go down to like 0.6. Does everybody see how that works? All right, cool. So we turn off the gas. She wakes up. It's a miracle. She'll survive to come see us again for something else. All right. We're going to talk a little bit about some of the local anesthetics. So there's a variety of dosings that we use for our local anesthetics. I think one of the biggest things that people run into is knowing which local to use when. And there is some variation depending on like where you go as far as practice, who uses what. But I think the big thing for you to think about is how you're going to classify them as far as like duration of action. So the three most common agents we use are lidocaine, bupivacaine and ropivacaine. You may use the others from time to time, but those are the most common ones we use. Generally, when we're looking for a fast onset and a short-acting local agent, we're going to use lidocaine. Longer acting, we're going to use either bupivacaine or ropivacaine. Remember that the longer acting agents tend to be a little bit more cardiac toxic. So just be cautious with that to make sure you're not intravascular. If you are, the last instructions are over there on the side for you. Other things you may see, what can we do to prolong the duration of action of our local anesthetics other than using a longer acting agent? Yeah, you can add epinephrine to this. What if I want to speed the onset of my local anesthetics? What can I do to make them have a faster onset? Yeah, bicarb. Now, with that being said, you will very rarely see anybody use bicarb to speed the onset of things. Usually what you'll see is a combination of a short-acting local anesthetic and a long-acting one. So you may mix like lidocaine and ropivacaine half and half. So you get the fast onset, but you also get a long duration of action from it. Does that make sense to everybody? Do you guys have any questions about local anesthetics? Make sure that you review these pretty well, especially right before you start your OB rotation, because that's when they're really going to drive and ask questions about local anesthetics. All right. Moving down, talking about the other antiemetics, Zofran and Decadron are by far the most common that we use, but you'll see stuff like droperidol has made a return. Kind of standard dosing for that is 0.625 milligrams. It's not weight-based. You may also see that other agents, similar agents like Haldol are being used. Haldol is usually like 2.5 to 5 milligrams. With the use of other agents, we've kind of gone away from using Phenergan quite as much. But if you do, remember it does have a lot of sedative properties to it. So dosing 6.25 to 25 milligrams. Think about how much you're giving the patient and kind of when you're employing it. So if you have somebody that is getting antiemetics like prophylactically, Zofran and Decadron are fine. If they're already puking or they're already extremely nauseated, you probably need something a little more powerful, like promethazine or droperidol, Haldol, something like that. Another thing for you to think about when you start looking at agents, onset time for scopolamine is very long. So if you have somebody that's getting ready to roll back to the operating room, putting a scope patch on may not be beneficial for them at all because the case will be done before it kicks in. You may also see that scope patches get left on and people kind of think about them being pretty innocent. I had a guy last night with a gangrenous gallbladder and he still had a scope patch on. He came down from the floor obtunded, primarily due to his pathology. But having a scopolamine patch on somebody that's a little bit older is not going to help them be awake, alert, and oriented by any stretch of the imagination. So don't neglect the bad things that come from little stuff like lidocaine patches, scopolamine patches, that sort of thing. Another thing to be cautious with, administering metoclopramide to patients that are wide awake. You will have all sorts of reactions to it. It could be extrapyramidal symptoms, or you could see they become extremely anxious. I've heard of like people just randomly taking their clothes off, starting to hallucinate, all sorts of crazy things. So if that's not what you're looking for in your patient, you may want to consider avoiding it. If that is what you're looking for in your patient, you're probably in the wrong profession. And there's probably better medications to do it too, but that's okay. Things to keep in mind when you start evaluating your patients for POMV risk factors: female, younger, previous history of POMV or any sort of motion sickness, big cases, especially in the abdomen, the eyes, the chest, ears, things that tend to throw off your balance, stuff like that. I know the answer here is if they don't have any risk factors to use non-pharmacologic treatment, but nausea and vomiting is a huge dissatisfier for patients. So even if somebody has no risk factors, I'm probably going to go ahead and at least give them some Zofran. Other things for you to think about, we talked a little bit about Toradol, but other non-opioid analgesics that are available to you. You can utilize PO Tylenol. You can also utilize IV Tylenol. Since it's come generic, it's a lot cheaper. It still costs more than PO Tylenol, though. So if you have somebody, you can give them PO Tylenol up front. It's probably a little bit better. The IV formulation of ibuprofen is called Caldor. It's not very popular. It's still kind of expensive, but there are some places that use it all the time. All right, we're going to hop over to the other page. So most of what's on this other page is going to be like different formulas and stuff for you to remember. But there's a couple important things I think you really need to pay attention to. One of the big ones is treatment of laryngospasm, because this is going to be a real life. This is something you're going to have to work through on a regular basis when you're starting off. Over time, you figure out how to not have all your patients have laryngospasms. But in the short term, you need to anticipate this. And it's just like anything else with your airway. If A, then B, then C. So first thing is make sure you're trying to prevent it. So airway suction dry, patients either awake or asleep enough that their airway reflexes are blunted. If they do happen to spasm, start off with positive pressure ventilation. So close that APL to like 70, get a good seal with that mask. And then if that doesn't work, to break it. And, if you're having a hard time breaking it, move quickly to doing something else. A lot of times what I'll do is a combination of positive pressure, and then I'll use my thumbs to do the Larson's maneuver to hopefully break that spasm. And then finally, if that doesn't work, you can go to succinylcholine. Almost think about that 1/10 dose like we were talking about for precurization, so like 10 to 20 milligrams. Very rarely will it get to the point that you actually have to give sucks. When I was in residency, we had a pediatric anesthesiologist that I couldn't figure out if he was crazy or if it was just like his mission to create all these laryngospasms for us. But he would have you pull the tube out in phase 2, would stop you from suctioning, all sorts of things that you knew were going to cause problems for you. And I had to give sucks a couple of times then. I've probably only had to give sucks to an adult once or twice to break a spasm. It's far more common in kids. A word of caution, in pediatric patients especially, if you're having to give repeated doses of sucks, it tends to cause bradycardia. So keep your atropine close. Just some lab dosages up here for you. MH dosages are a big thing. So starting dose 2.5 mg per kg IV, and then you can repeat it about every 5 minutes till you get to 4 dosage, which is usually 10 mg per kg. Other things for you to think about that you'll use commonly during cases, and it's a good pimp question for the operating room because people are going to want to know and see that you're thinking appropriately about things. So almost all the medications we give will cause your blood pressure to go down. You have to look at the clinical picture when you're deciding what agent to use on which patient. So good references for you. If your patient is hypotensive and bradycardic, ephedrine is probably a good choice for that patient. Almost everywhere you go, you're going to have to reconstitute ephedrine or at least draw it up. The usual concentration is going to be 50 milligrams in 1 ml. There are some places that have 50 milligrams in 10 mLs, but you're still going to wind up with that concentration being 5 milligrams per ml. So if you have a hypotensive bradycardic patient, ephedrine will be your drug of choice. If you have somebody that's hypotensive in normal heart rate or tachycardic, neosynephrine may be a good choice for that patient. Again, something you're going to have to reconstitute. So it's going to come in a 10 milligram in 1 ml vial. 10 milligrams, not 10 micrograms. So make sure you dilute this. I'm aware of situations where both of these were pushed undiluted, and kind of a wild ride for the patient's blood pressure after that happens. So you're going to dilute your neosynephrine in a couple different ways. The most common is 10 milligrams and 100 mLs, which gives you a concentration of 100 micrograms per ml. There are some places where they dilute 10 milligrams and 250 mLs, which will give you a concentration of 40 mics per ml. Just be familiar with whatever the practice is at your facility. Like I said, it does vary quite a bit. Some places you go, they have pre-filled syringes of phenylephrine, but again, you'll have very concentrations. You may have 100 mics per, you may have 40 mics per, you may have 80 mics per. So just know what you have available to use. On the other end of things, a lot of times intraoperatively and postoperatively, we'll have to address the patient's hypertension. The good news for us is that, like I said, almost everything we give lowers your blood pressure. So we may give propofol to lower the blood pressure as opposed to getting out something else. So kind of our go-to agent if you have a patient that's tachycardic or normal heart rate and hypertensive is labetalol. You'll see effects on heart rate and blood pressure. So labetalol, usually we start off at like 5 mgs. It's not weight-based, it's just 5 milligrams. So 5 to 10 milligrams. It's usually supplied either in a pre-filled syringe with 5 milligrams per ml, or you may have to draw it up. And it's usually in either a 20 milligram or 100 milligram vial if you draw it up. So just be cautious with it there. So that was if we had somebody that's normal heart rate and hypertensive or tachycardic and hypertensive. If you have somebody that's tachycardic and hypertensive or just tachycardic, esmolol is a good agent for you to use. It's usually supplied 10 milligrams per ml in a 10 ml vial, but they do make bags of it as well that a lot of times you'll use for stuff like ruptured AAAs or threatening AAAs, that sort of thing. Good starting dose is 10 milligrams. Usual dose is 10 to 30 milligrams. Now, on the other end of things, if you have somebody that is hypertensive and bradycardic, hydralazine is your go-to agent. Just be cautious with this. One, make sure you reconstitute it. Usually when we reconstitute it, we do either 4 or 5 milligrams per ml. So it usually comes with 20 milligrams in 1 ml. So when you're doing that, you're going to go through and dilute it down to either 4 or 5 milligrams per ml. And then usually you'll push 5 at a time. Be very cautious using hydralazine because it's got a lot longer onset time than what we're used to. So while you expect things with labetalol and esmolol to be very quick, hydralazine's onset is a lot of times 5 to 15 minutes. So, we want instant gratification, but be very cautious because you may wind up giving dose on top of dose and then you're chasing your blood pressure on the other end. Austin asked, if you end up wasting so much, why do they not have a lower concentration to start off with? Are you talking about for neosynephrine, Austin? So a lot of times the practice will be that you will use a bag of medications cleanly for a day. So for instance, like neosynephrine, you may mix up a bag and then you use it the whole day. So some cases you may not use any of it. Some cases you may use multiple. Sometimes you may have to take that bag and hook it up to a pump and infuse it. The big thing there is it comes down to money. It's not that expensive. On the other hand, stuff like esmolol is expensive. And then the other part is just availability of the product. With all the crazy like supply chain issues we run into, like right now we have ephedrine 10 milligrams and 10 mLs, or excuse me, 50 milligrams and 10 mLs is our ephedrine, whereas everywhere else have always had 50 milligrams per ml. So it just depends on what your facility can get. And then the other thing you have to take into account is the pharmacy, because things that make a lot of sense to us don't make sense in pharmacy land. If I had 10 boxes of a medication and I only needed to use 1 box, I would probably just use 1 box. The pharmacy is going to say, well, they all came off the same drug, so you need to use all 10 boxes. Or, similar situation like ketamine. Ketamine's in short supply right now. Ketamine comes in a 50 or 500 milligram vial. Very rarely are you going to use all 500 milligrams. So in my mind, I would say, hey, why don't I draw this up into smaller dosages and give people 50 milligrams instead of, wasting it every case? That doesn't make sense in pharmacy land. But that's another example for you. All right, any questions about that? All right. So we're going to go back and look at the last two Anasoft cases. If you do think of drug questions, please feel free to ask, because this exam is really just making sure that you're prepared for clinicals. In any medication that you've had while you've been in the program is fair game. So just because we didn't talk about it today doesn't mean you don't need to know the dosage of it, especially if it's something that you're going to commonly use. So first case is a 51-year-old male for an XLAP. And I know it's been a little while since you guys looked at these, so we'll just kind of talk through it together. So 51-year-old comes in for an emergent XLAP. He was in an automobile accident. He's got bleeding inside his belly. Most common areas for bleeding are going to be the spleen and the liver. Looks like it's spleen for this guy. We don't really know any history about him, allergies, meds, any of that sort of stuff. He's a little bit round. He's intoxicated. And of course, he's still in pain. He's not breathing well to start off with. Is that because he's in pain, or is that because of an underlying issue? Hemodynamically looks okay. He's not real tachycardic. Blood pressure is a little on the lower side. He is breathing fast. Hemoglobin and hematocrit look okay. He's got some contusions on his left lung. Those will not magically get better under anesthesia. So be very cautious about like large fluid boluses for this patient. You'll see that if you've got people with pulmonary contusions and you give them large amounts of fluid, that it tends to make those pulmonary contusions worse. So, of course, he ate and drank right before the accident happened. And the surgeon is amazing. He's estimated it will only take him 2 hours to do this case. We all know better than that. So with surgeon math, you basically have to double whatever they tell you. So things to think about for this guy. One, there may be other injuries that haven't been diagnosed yet. So things I worry about, like I said, pulmonary contusions, rib fractures. If you've got somebody that took enough of an injury to the chest to wind up with a pulmonary contusion, they're also at increased risk for pneumothorax, especially under positive pressure. From an anesthetic standpoint, I'm probably going to go ahead and put an arterial line in this guy so I can get labs. He's bleeding. I'm probably going to want to check serial H&Hs on him. May also want to keep an eye on his blood pressure. As they get into his belly, they tend to tank. How do you guys think we should secure his airway? What's a good anesthetic plan? Yeah, so RSI. So when we talk about an RSI, what does that mean? Because we throw it out there, and then when we actually come down to having to do it, sometimes it's a little confusing to us. So a couple things to think about. One, quick onset. So you either need to use a large dose of rock or sucks. Either one is appropriate. From sedation standpoint, think about his blood pressure. It's 100. He's bleeding. We're a little worried that he may tank his blood pressure. So I may not give him any fentanyl on induction. I would probably be cautious giving him propofol, just because his blood pressure is a little bit on the lower side. So I may consider giving him midazolam for amnestic effects and then doing a lower dose of propofol. Or I may consider using something else like etomidate. Marcus made the comment about sucks and prop mixed in one syringe. I would caution you to avoid that because you're going to have to waste all your controlled substances. So if you've mixed sucks and propofol in one syringe, you're not able to account for it. The other thing is that if you're administering your sucks and propofol at the same time, he may be very well being paralyzed without any sort of sedation. So always try and get your sedative in before your propofol. So cricoid pressure, succinylrock, propetomidate, ketamine, something like that, and then tube and trachea. So this guy had some issues afterwards. He was hard to ventilate. Make sure you work through your dope mnemonic. So is our tube displaced? Has it been right main stemmed? Is there an obstruction? Do you have like a mucus plug? The most common obstruction we run into is just the tube not being supported and it winds up kinking itself off, or the patient getting light and starting to cough and buck on the tube. But go through. The other thing is just start at one end or the other and troubleshoot things. Usually I start at the tube and I work through the patient factors. So that dope mnemonic, is it displaced? Is it obstructed? Does the patient have a pneumothorax? I'm already thinking he's pretty high risk for pneumothorax because he had enough pressure on his chest to wind up with a pulmonary contusion. So that's a pretty high differential for me. Something else to think about is potential for bronchospasm. He's got pulmonary trauma. He may have asthma we don't know about. We didn't get any great history on him other than he's been drinking and he ate a whole bunch of food before he came to the operating room. So that's a possibility there as well. Something else for you to think about, a lot of times in polytrauma patients, things get missed or don't get passed along. I'll give you, for instance, we had a guy this morning that was an MVA. He had an open hemothorax, the left chest, his left lung was hanging out, and then he had a tension pneumothorax on the right side. They had decompressed that right side, but they never put a chest tube in him. Nobody said anything about it, and the only way we found it was there was a needle catheter sticking out of the side of his chest. He had, left side's not going to get a pneumothorax or hemothorax because it's open, but we've done nothing with that right side. So things like that can get missed, or, they've got a scalp laceration that starts to bleed, stuff like that. So just think about things like that happening. And like I said, especially under anesthesia, it's hard to assess the patient, but pneumothoraces are definitely an increased risk, especially with like chest trauma. Isaac asked, would the trauma scans that are done in the ER identify a blunt cardiac injury, or would you find out about that as you're inducing? So a couple different things that will help you kind of figure out if your patient has blunt cardiac injury. The biggest one is going to be mechanism. So they took a good whack to their chest. Well, he took a good whack to the chest. Next thing would be looking at EKGs. So if you happen to have a 12 lead, it may show you evidence of it. You may see it just with like a little bit of ischemia, especially on induction on a 3 lead. Or you may find out the hard way, like as you're inducing, that he starts to demonstrate some ischemia. Otherwise, it may be a matter of just doing like a cardiac workup after the case. But usually your CT scans are not going to show you blunt cardiac injury. They may lead you down the pathway that makes you suspect it, but they're not going to confirm it for you. So this guy got in there, had surgery, did okay. Moving on. Any questions about this case? Like I said, I know it's been a while. This is a pretty common case, and it doesn't even have to be trauma. Probably more often what we see is that patients come in with like a perfed ulcer, and they wind up with spilled gastric contents or free air or something like that. All right, I'm gonna hop over to the other case. So this was a 4-year-old that came in for tonsils and adenoids. Pretty common pediatric case. So things you have to think about for pediatric patients coming in for tonsils, a lot of times just because of the pathology of needing the surgery, they'll have recurrent ear infections. So you kind of have to try and get this in between their healthy periods. The other thing you'll see is because of those inflamed tonsils or those large tonsils, they tend to have sleep apnea as well. So mom, dad, brother, whoever may report periods of pauses in breathing or snoring loudly. So he was pretty common from that perspective. He's also a little bit fluffy, so just be cautious with, fat kids going to sleep. The biggest problem we run into with large pediatric patients is that they're kind of hard to find IVs on. So think about hands are a big one, and then like ACs. Usually forearms on kids are hard to find, but those are my two kind of go-to places. Labs look good. Heart rate, blood pressure, all that stuff's good. His hematocrit's 48, which is probably a little hemo concentrated. But these are usually pretty quick cases, so I don't worry too much about it. So things to think about, like I talked about, think about sleep apnea. One of the big things we worry about, whether it's an adult or a pediatric patient, is if they have sleep apnea, you may have kind of an increased risk of obstruction when they're waking up. So you may consider putting an oral airway in them. The other thing is just make sure they're fully awake. If they're not able to support their airway when they're awake, it's not going to be any better when they're sedated. Stop and evaluate these kids really well. We used to use fiber optic scopes for all these patients. Now you may go to a pediatric glide scope. Things you have to think about: do you have pediatric emergency equipment like a pediatric glide scope? Do you have stylets for the glide scope? A lot of times we have a bunch of adult equipment, but our pediatric equipment is lacking. The good news is pediatric airways tend to be not difficult. And if they are difficult, it's usually in like kids with different syndromes. So that's kind of like double warning there. They may have a difficult airway and then they've got all these syndromic concerns. So that's something to think about there. The other concerning thing with this kid, just based off his history, he's not tachycardic, he's not febrile, but a lot of the times with these kids, especially if they're kind of presenting with a more acute onset, I may consider epiglottitis for these patients. So take a look at them. Usually you can, see what they look like. If they're sitting up, they're drooling. There's probably something more to this than just tonsils and adenoids. So be very cautious with those patients. Other things to think about: if you've got somebody, adult or pediatric, that they're snoring, they're not oxygenating well, they can't stay awake, they probably don't need any like pre-sedation because they can't stay awake at baseline. So I would be concerned about giving them sedation, especially before I pre-oxygenate the patient. You'll see, and you're going to do it, and then you'll do like better for a while, and then you forget again. You will hose yourself trying to pre-oxygenate your patient. So make sure that they are well pre-oxygenated before you get a whole lot of sedation in there. If they're so sedate they can't move themselves over to the stretcher after 2 milligrams of Versed, they're probably not going to oxygenate real well for you either. So just something for you to think about there. Other things to think about with this specific patient: if it's his tonsils and his tongue that's problem, usually an oral airway will be enough to bypass that. And then finally, during the case, be cautious about what you're giving him that may affect his mentation on the back end. If he's really sedate, he may not oxygenate well on the back end either, except now he's got a little bit of bleeding in his mouth. He's got, a little bit of risk of laryngospasm because he's got this extra fluid in there. So things like that you have to think about when you're doing these cases. All right. Any questions about either one of those? All right. Yeah, go ahead.
I was just saying no, sir.
Oh, okay, cool. On Thursday, we'll just kind of run through the PowerPoint. I wanted to give you guys a couple more days to look at it and think about things. So if you have questions, this is like your chance to ask. If there were any Pharm questions that came up that you're not sure, or you want to know how things work, or any of those sorts of things, I'm happy to kind of run through those with you. On Thursday, we'll kind of talk through a couple more scenarios. We'll go through the PowerPoint. Just a couple announcements for you. If you're interested in BlockBuddy, I published the discount code for you. ANA is taking care of that for us. So the discount code is just MEDIC5, and it's good till next November. So if you're not sure that you're going to want to buy it, or you're not sure you'll need it, you've got a little time in there before you have to spend the money. It is a subscription-based thing. Yeah, I think it's like half off. That's what they usually do. The course evaluation is open in Typhon, so please fill it out in the next week and tell us what you liked, what you didn't like. I really do appreciate the feedback so we can work on tailoring things for the future. We're constantly revising courses. As far as the Pharm test, it will be 60 questions. You'll have an hour and a half to do the test. Most of the questions will be kind of like we talked about today, scenario-based questions. So you'll just get like a short blurb about the patient and then, be asked about a medication or an intervention for the patient. There are some things looking at like how medications work, stuff like matching up, MAC values, stuff like that. So just think about those things when you're going through and studying. Other things I would make sure I paid attention to, get a couple like uppers and downers that you learn really well. So think about your vasoactive infusions. Probably the two most common ones that we use are norepinephrine and phenylephrine. Know how to mix it. Know why you would use one versus another. Think about other agents that may have cardiac effects. So if you've used phenylephrine and you've used ephedrine and your patient's still hypotensive, what are you going to go to next? Do you go to vasopressin? Or are you going to go to calcium? Things like that. Are you doing norepinephrine pushes? Are you doing epi pushes? But you're going to have to not only know when you would use it, but also how to make it happen. So, and think about how I would reconstitute this to give whatever dosage I want to give. I decide I want to push 16 mics of Levophed. Now I know I've got to triple dilute to get to that 16 mics. So think about the logistics of all these things ahead of time. Same thing for like your antihypertensives. Probably the two most common ones we use are nitroglycerin and nicardipine. But what if we don't have any of those and you're having to use esmolol or you're having to use nitroprusside? Each one of those have like benefits, but they also have a lot of cautions that go with them. And the dosing is very different from one to the next. Some things you may be able to drop on a syringe and push. Others you're going to have to put on a pump. You may have to get special tubing. You may have to reconstitute it. So think about all those sorts of things. One of the things I wanted you guys to look at as far as, I provided you with like our medication sheet, but there's a couple of others here too. And there's a lot of information out there on the internet. The other one I put on there is from UCSF. A lot of commonalities to what we have, but they kind of take things and break it down by like OB issues. So, if you got an OB patient that's got postpartum hemorrhage, here's my methogen. I'm giving 0.2 milligrams. Okay, that didn't work. I'm going on to my Hemobate. Which ones can I give IV? Which can I give IM? Can I give TXA for this patient? Stuff like that to think about. When you start getting into your specialty rotations, there will be more things that you may use just there. I don't use Pitocin in my everyday life, but when I'm doing OB, I use a lot of Pitocin. Same thing with like your drips. You may use like Amicar when you're doing hearts, but you may not use it for anything else. So some of those things you'll study up a little bit more when you get to your specialty stuff, but you need to be familiar with it in the meantime, just to think about. They have a really cool list of medications on the UCSF one that I think is kind of helpful. And it's got dosing, it's got duration of action, stuff like that. So I would definitely go through and look at that one as well. You will see, depending on where you go, that there's quite a bit of variability for dosing. Just like, the doses on here may be different than the doses on the Texas Wesleyan, the one that we give you. Most of the time, they'll be fairly close together, but there may be a little bit of variation there. So just think about that. From a test question standpoint, I try and make sure that all the questions are not ambiguous. You're not confused about dosing because one table said one thing and one table said another. It tried to be pretty straightforward. You need to be able to do basic math without a calculator. If you have to pull out your phone and pull out your calculator to figure out how much of a medication to administer or how many kilograms your patient weighs, you're probably going to get sent back to third grade and get to work on it a little bit harder next time. If you're doing like complex math, you need to be able to realize that I may need to write this down or I may need to pull out a calculator. So just things to think about. Natalie asked if there would be peds dosing. Potentially. A lot of these medications are weight-based, so it doesn't matter if it's an adult or a kid, especially like with antibiotics. But, like I said, you can't apologize to the kid that you didn't know that he needed, X dose of a medication because you didn't know that it was on the test. So I would definitely study my peds doses as well. There may be some questions on, patient has renal failure. What medications might not be a good idea for the patient? Not necessarily worded like that, or contraindicated. Or, in pediatric patients, you may have to change this because their MAC is highest at what age? Stuff like that. So, does that make sense? All right. Any questions on anything? Thank you for asking, Samantha. That was the next thing we were going to talk about. There are people that have still not turned in like license copies, stuff like that in Typhon. I think there may have been a little bit of confusion for what you upload. So I'll take Texas, for instance. And I think Dr. Kane used, maybe this is a specific example. Like when you get your nursing license in Texas, it's just congratulations, Brian, you got a nursing license. Here's a whole bunch of fancy writing, here's a big seal. It doesn't actually say the license number or expiration date, stuff like that. So for submission to facilities, we need all that information, license number, date of issue, date of expiration. So it may be a matter of taking a screenshot of the licensure verification, not showing the fancy nursing diploma that you got, stuff like that. There are some people, and the vast majority of people have uploaded everything. There are some other people that have not uploaded anything. So if you're one of the people that has not uploaded anything, you may be struggling to get to clinicals. Please don't make Natalie upset because she's a pretty patient person. But, we've asked multiple times to kind of get stuff going there. If you have stuff that's showing is incomplete, please reach out to Natalie or Dr. Schaefer. I think it's probably Natalie, to get that squared away. As far as specific vaccinations, whatever they told you needed to have, please make sure you have it. I don't know that they're all requiring COVID vaccinations. But, if that was one of the things you were told you had to have, please get it there. Josh asked about talking about place in Typhon for uploads. Yes, in Typhon, please upload it there. I'm not sure what specifically JPS has. Just like I said, reach out to Natalie and touch base with her if there's something it's showing as incomplete or something it's missing. All right. Any other questions about anything related to class or clinicals that I may be able to answer? Okay, there you go. Marcus said, Typhon, you need flu, TB shot, and COVID. So there's your answer. Any other questions? All right, that's all I've got. I will see you guys here on Thursday.
Thanks, Dr. Cornelius. Have a good day.
Yeah, no problem. You guys too.